Thank you, Laurent. Thanks again for inviting me. And this will be my pleasure to try to explain to you how respiratory muscle activity could protect patients from ventilator-induced diaphragm dysfunction. So here are my disclosures that haven't changed. So ventilator-induced diaphragm dysfunction is a concept that has been discovered like 20, 15 years ago. And here on this graph, you have the force that can produce a strip of diaphragm of a rat exposed to 24 hours mechanical ventilation, 18 or 12 hours, and the control rat that has not been mechanically ventilated. And as you can see, the mechanical ventilation decreases the force of the diaphragm, and this impact of mechanical ventilation on the force of the diaphragm is time dependent. And it took 10 years to get similar results in humans because it's quite difficult to investigate the diaphragm force in mechanically ventilated patients. So probably the most reliable way to do it is to use phrenic nerve stimulation and to measure the pressure in response to the stimulation of the phrenic nerves and to measure the pressure at opening airways. And this is the signal that we get. It's called a twitch. And what has been observed by the Samir Jaber's team from Montpellier, it's a typical trace of a patient. So at admission, there is no dysfunction of these patients. And on day 3, no dysfunction. And on day 7, there's a strong dysfunction that appears. And on this first report on the 6 patients, what we have is a slow decrease in the diaphragm force along the ICU stay. So it's exactly what happened to Arnold Schwarzenegger, when he... And the pathway of ventilator-induced diaphragm dysfunction, it took years to understand what was the mechanism of ventilator-induced diaphragm dysfunction. I'm not going to get into that, but just to give you some insight. So what happened is that mechanical ventilation caused diaphragm unloading, and this unloading caused a huge oxidative stress and an imbalance between protein synthesis and proteolysis. And this, in turn, caused myofibers injury and myofibers atrophy, and then eventually diaphragm dysfunction. So why going through that? Because if we want to prevent ventilator-induced diaphragm dysfunction, then we need to know all these mechanisms. And what is funny with research, with basic research, is that for each of these given mechanisms, there is a specific blocker. So you can block the NF-kappa B, you can block block the oxidative stress, you can inhibit protease, so you can do everything, whatever you want. But to be honest, none of these blockers can be used in patients, but maybe some, like an acetylcysteine, they can be given to patients. And what we have, this is the typical experiment on animal. So you have the control animal, no diaphragm dysfunction. So here is the diaphragm force. And in the control animal, you have no dysfunction. The animal who's mechanically ventilated, there's a strong dysfunction. And if you give NAC to the animal, it prevents the ventilator-induced diaphragm dysfunction. And the mechanism, one of the mechanisms possible is a reduction of calpain activity, which is a strong protease. And as we can see here, as compared to the control animal, the one that has been ventilated has a strong calpain activity and NAC with prevent calpain activity. So why talking about all these pharmacological blockers is that because we cannot use them in humans. So, you know, it's very theoretical, and we won't give that to patients. So the only thing we can do with our patients is to promote the assisted mode of mechanical ventilation. This is the only thing we can do, and this will fight the diaphragm unloading. And actually, the benefits of promoting some spontaneous breathing in mechanically ventilated animal has been demonstrated in this nice paper. So here again is the force of the diaphragm. So as compared to the control animal, those who received mechanical ventilation have a strong diaphragm dysfunction. And if you introduce a proportion of spontaneous breathing, then it prevents somehow the diaphragm dysfunction. So yes, promoting some spontaneous ventilation will fight with the diaphragm dysfunction. And so this is what we had in our patients. The first patient I showed you, on day 7, there was a strong diaphragm dysfunction, and the patient was switched from controlled ventilation to pressure support, of course, because he had recovered. And then we see that the diaphragm force is increasing. And this is the recording of a patient who never received controlled ventilation. He was on pressure support from the beginning, because it was a story of upper airway. And in these patients, we never observed any diaphragm dysfunction. So how does it work? How pressure support could prevent diaphragm dysfunction? And basically, it works on all the mechanisms. And for example, we have here the proteolysis in diaphragm of an animal. And as you can see in the animal who received controlled mechanical ventilation, there's a huge increase in proteolysis and a strong decrease in protein synthesis. And then when the animal is turned to pressure support ventilation, then it prevents proteolysis and protein synthesis increased. So somehow pressure support ventilation can prevent proteolysis and protein synthesis. But the difficult thing is that it's not only controlled mechanical ventilation that induces the diaphragm dysfunction, is a strong unloading. It's too much unloading induces diaphragm dysfunction. And that's what shows this paper. We have dysfunction with controlled mechanical ventilation, but there is also dysfunction when there is a pressure support with a too high level of pressure support. So too much unloading, whatever the mode, will induce some ventilator-induced diaphragm dysfunction. So the clinician, the physician, is facing an issue. So if the patient is too much assisted, then it creates excessive unloading and diaphragm atrophy. But if the patient is not assisted enough, then it will generate respiratory discomfort, asynchrony, and all these things. So we have to keep the balance, and this is not easy. And this is probably there is a room here for proportional modes, because as opposed to pressure support ventilation, which provides the same level of assistance irrespective of the respiratory muscle effort of the patient, proportional modes will deliver a level of assistance that is proportional to the respiratory effort of the patient. So if the patient developed a strong inspiratory effort, here he will receive a high level of assistance. But if he doesn't develop a strong level of assistance, then he will just receive, if he doesn't develop a strong inspiratory effort, he will receive a low level of assistance. So there is a constant adjustment of the level of assistance to the intensity of the inspiratory efforts of the patients. This is the case of NAVA, of course, where as we can see here, we have here the EDI and here the pressure. As you can see, when the EDI is kind of quite low, then there's a low level of assistance, and here we have a higher EDI, and then we have a higher level of assistance. And we have quite the same with PAV. Here the level of assistance is here, and is here, and here is the esophageal pressure. And as you can see, when we have a huge inspiratory effort, then the patient receives a high level of assistance, and with a low level of assistance, the patient receives a low inspiratory effort, the patient receives a low level of assistance. And actually, both modes provide the same adjustments in terms of assistance and of giving a high assistance to patients who have a high demand and a low level of assistance with the patient who have low demand. So now let's move on to some perspectives. So there is this proportional mode that could help us to adjust unloading and to never unload too much the diaphragm. But we could also imagine a system that will restore the activity of the diaphragm in a mechanically ventilated patients. So one of the techniques we could use is phrenic nerve stimulation. And this, so to restore the activity of the diaphragm, we could stimulate the phrenic nerves with electrodes that could place with the laparoscopic way. And you can insert electrodes into the diaphragm, like that. And this is a work from a group in sheep. And as you can see, as compared to the animal who just received mechanical ventilation, the one who received mechanical ventilation plus phrenic nerve stimulation has a much more preserved diaphragm. This one, there is a huge amount of edema and infiltrates, and there's a fiber disruption in this muscle. And as you can see, this one is much more preserved. And it also preserved diaphragm atrophy. As you can see, in the mechanically ventilated animals, there is a huge atrophy, and this is quite preserved in those who have been stimulated. So that's an interesting perspective. It also preserved mitochondrial respiration. So this is in patients, and you have on the right the stimulated patient, and on the left the control patients. And stimulation preserved somehow the mitochondrial respiration. So the last thing, what we could, so all these techniques like electrodes seems a little bit complex in the patients. And what we could do in patients maybe is to restore the phrenic activity using some repetitive magnetic stimulation of the phrenic nerves. So this is a non-invasive technique, so we stimulate the nerves like that, and we did a trial in healthy subjects just to evaluate if it was possible. And with repetitive magnetic stimulation, we were able to restore the force of the diaphragm. As you can see here, we have here the PDI as a who is expressed here, and here the stimulation frequency. And as you can see, with the repetitive magnetic stimulation of the phrenic nerve, we can produce some diaphragm force and maybe preserve the force of the diaphragm. So in conclusion, respiratory muscle activity to prevent ventilator-induced dysfunction. So there's a lot of pharmacologic agents. They have been evaluated in animals, but to date, none has been evaluated in humans in a large study. So the only tool we have is to promote spontaneous ventilation using pressure support as soon as possible. It's not dangerous. And also to use proportional modes that could help us to adjust the level of assistance. And on the future, maybe we could have non-invasive diaphragm stimulation that could also prevent ventilator-induced diaphragm dysfunction. Thank you very much for your attention.
Thank you very much, Alexandre. We have time for a couple of questions. Yes, Brigitte, if we can have a microphone.
Yes, Alexandre, thank you very much for your nice presentation. I have two questions. What's the role of shear stress in diaphragmatic dysfunction? And second question, on patients who are on non-invasive mechanical ventilation. They often use it intermittently, even in the ICU. Do you have an idea of the time or the periods of spontaneous breathing that could prevent diaphragm dysfunction in patients in the ICU on non-invasive mechanical ventilation? Alternating spontaneous breathing periods with NIV, does that protect?
So there's no data on non-invasive ventilation and diaphragm dysfunction. All the data, we have a lot of animal data on ventilator-induced diaphragm dysfunction. There's a lot of animal data. And most of them are with controlled mode of mechanical ventilation. So there's very few data with non-controlled mode of mechanical ventilation in animals, and there is not really data with NIV. And in humans, there are very few studies. There is one or two studies, yes, 2-3 studies only in humans, and the role of NIV and yeah, no, this has not been investigated. So it's impossible to answer your question with very, with scientific data. But so that's a very good question. The problem of VIDD in patients is that it's not working as well as in animals, because the model of VIDD in animal is very pure. You take a healthy rat and then you induce diaphragm dysfunction with 24 hours of mechanical ventilation in a nice environment. He has no other disease, nothing goes wrong. But if you consider a patient, he undergoes mechanical ventilation, but there is the sepsis, there is like the sepsis on admission, nosocomial pneumonia, there will be hyperglycemia, there will be neuromuscular blockers, and there will be a lot of confounding factors. So it's very, very difficult to study VIDD in a patient because there is so many confounding factors that it's very difficult to study it. So making a study on the, only to prevent VIDD during NIV, it will be very difficult to design.
Alexandre, I would be a patient in your ICU.
Yes.
I would prefer to take some pills, some antioxidants, than having a laparoscopic placement of phrenic nerve stimulation. So why do you say that there is no place for medication?
No, I'm not saying that there is no place for medication. I'm just saying that all these medication, they haven't been assessed in humans. And the fact is, if you consider a given study with blockers, it always works, always. So you take any of these blockers, you give it to the animal, and then you prevent diaphragm dysfunction.
That's a good start.
Yes,
okay.
That's a good start. That's a good start. But any of them, and most of them, you're not, as you know, like NAC and acetylcysteine. We have tried it in dozens of diseases in patients, and it never worked because it's not the same model. Patients are very complex, and there are many other mechanisms that what there are in animals. So, but if you come to my ICU and if you want, I can give you a lot of these.
Okay.
I have some in the fridge, so.
Great, I'm reassured. Leo, question? Sorry.
Yeah, thank you for your great talk. But it indeed looks like that assisted ventilation can attenuate VIDD, but in some patients, well, we need controlled mechanical ventilation for a few days. So do you have any idea how much, in these patients, how much activity of the diaphragm we need to prevent VIDD? I mean, if we do a few magnetic stimulations a day, would that be enough? And I'm asking because I'm so surprised by the data from Daniel Martin that shows that training the diaphragm only needs a few loaded breaths a day in patients that are on the ventilator, right?
Yes, that's very interesting data. But yes, we don't know yet, but probably not so many periods of stimulation would be enough. Because on the animal, if we look inside the animal models, most of the models in which spontaneous, assisted ventilation or some spontaneous breathing protected the diaphragm, in these models, it was like 5 minutes each hour. So it's not a lot. And this should be enough to protect the diaphragm in a pure model of VIDD. But I don't know, in ICU patients who received many medications with the sepsis, I don't know. But a few should be enough.
Thank you. Great discussion. Thank you very much.